bursa, in that you've got this fluid in the knee itself, but you've also got the fluid behind the gastrocnemius, both heads. And all of this communicates. And when you flex and extend your knee, the synovial fluid moves. Hold on to that for just a moment, and let's do a patella now. Folks, in you, the patella is not stapled up here. It's not. It can move. Now, what I want you to do, you can do this on yourself, is extend your knee and let your foot relax on the ground. Just relax. There shouldn't be any muscle contraction. Now take hold of your patella and move it around. Feel how it moves?
Look at Shay's.
Yeah, you come up here. You volunteered to be my subject. Well, both of you come up here now. More pretty girls up here, the better. Okay, relax. Now, tighten your muscle. Ooh, ooh, doesn't move. Okay, it doesn't move anymore. Now, I want you to flex your knee all the way up. Where did her kneecap go? Come out straight. See that sucker sitting up there? Now bend your knee. Where did it go?
It seems like it's under the epicondyle or condyle femur.
Okay, so where'd it go? Huh? Well, I went proximal, yeah, that's next. It disappeared, almost. She's got a little bit of a bony kneecap here. It's down in the joint. It has gone deep into the joint. For you to flex your knee, the space has to increase and the patella's got to go into it. You think that's significant? Why? Go back to what we were talking about now. Why is that significant? It's significant for 3 or 4 reasons we'll get into, but we were just talking about the bursa and the synovial fluid. Where does the synovial fluid have to go? You got this big rock in there. It can't come forward, can it? So where does it have to go? Into the gastrocnemius portion of the bursa. How many of you think you're ever going to work with a patient with knee surgery? Right after they have knee surgery. How many of you want to hurt them real bad? And I'm not talking about physically hurt them. We all want to do that. That's why we're in physical therapy. We want to cause pain. But how many of you want to damage the knee after surgery? You sit up here real quick. I want to see something. Straighten your knee out. Now bend your knee. Oh, no, straighten it out again. Ooh. Oh. Scoot forward just a little bit. Now bend your knee down as far as it goes. Hers disappears even a little bit more, doesn't it? I mean, it's there, but it's not. Thank you. Why do I give a hoot about any of this crap? How many of you going into orthopedics? Only one, but the rest of you are going to work with knee patients? Isn't that orthopedics? What happens in a case of inflammation? If you had my med term, you know what inflammation is. Heat, redness, swelling, pain, and they added on loss of function because they weren't happy enough to know that if you have heat, redness, and pain, and swelling, you're going to lose function. Somehow that didn't seem to be necessary to add on, but somebody decided it. You get what? Heat, redness, pain, and swelling. After surgery, you're going to have a lot of, and here we're not talking about just edema. You'll have that because somebody cut into the soft tissue. But you're going to have increased synovial fluid because somebody said synovial fluid's function was to reduce friction. Well, what if I got an ouchie in there? What's the body going to say?
We need more synovial fluid.
Because we got friction. Let's add more synovial fluid. What happens when the joint swells? Okay. We got 3 things here going on, all of them important. Think them separately and then put them together. The fluid will push the 2 bones apart and also push up the patella, but I'm just right now interested in the tibia and fibula. In other words, there's space in there. You fill up a balloon with water or air, and it won't move very well. Okay. The most open packed position for the knee joint, which we're going to say in this case is the tibial-femoral joint, is about 30 degrees of flexion. If I have more extension, the bones get closer together. If I flex the knee more, the bones get closer together. Not only that, but you got the quadriceps pushing the patella down into that joint. So that a grossly swollen knee will assume about 25, 30 degrees of flexion. In arthroscopic surgery, one of the things you got to do is keep the bones apart. You know what they do? They inject water into the joint, which opens up the joint space so they can see it. But the knee is going to be here. The only way to flex or extend that knee is to burst the joint capsule. So if a patient comes in after surgery and is like this, I'm going to try to gently passively extend and passively flex. If I can't do it, I'm not going to start pushing on it. Because in order to gain range of motion, you must reduce the fluid content. Because this is the most open packed position. Now, how many close packed positions are there in a joint?
1.
1. How many open packed positions are there? Everything else. But this is the most open packed position. Okay. Now, I got somebody who's got some motion. He's been in a cast for a while, or he's post-surgery, and I can't flex it. I can't flex his knee. What are the 2 reasons we might not be able to flex his knee?
Adhesions.
Fluid and contractures.
Fluid and contracture. Yeah, you are right, but I hope not.
I had them. There's a reason why.
Well, the reason I hope not is because that's going to be a lot more of a problem. And you shouldn't get adhesions shortly after surgery. It should take a while.
It was 12 weeks.
12 weeks, okay. Well, you're way past where I'm working with you. I'm working early on. It's fluid and contractures. What contracture of what muscle would prevent flexing the knee? Why would you say hamstrings? If the hamstrings are short, isn't it going to flex more? What prevents flexion in tightness? Quads. Or if it's fluid, when I flex the knee, where's the fluid going? Back. So I say to the patient, I can't flex it. He says, that hurts. I say, where does it hurt? If he says it hurts here, what am I going to do?
Work the muscle.
Huh?
You have to stretch the muscle.
Stretch the muscle. If it hurts back here, what am I going to do? Huh? I'm certainly not going to push hard, am I? I'm going to do something to reduce the synovial fluid, or maybe wait a couple days and the body will do it itself. See clinically what this means? Your knowledge tells you a huge amount about what to do. And I know there are some people who think the PTA is only supposed to do what the PT says. You won't be my PTA. Because I expect my PTA to tell me what to do. I'm too old to remember. Keep that. But no, this is something that Angela Long had a physician who specifically requested her to work with his patients on total knee replacements. Okay, I had to go first. She let me go first because I got to fill out all of those forms. Make Medicare happy. But then she'd go in and do the job. Why? Because she worked with little old ladies a lot better than I did. They liked her. Okay. You with me now?